welcome everyone to today's KCQVIC forum. My name is Stacy Farr. Lovely to have you all here. So I'm going to just start off with a little bit of an introduction to today's session, which is on alternative payment models. So this is with the Healthcare Institute for Innovations in Quality, or HIIQ, at the University of Missouri, Kansas City. Oh, my clicker. All right, so to let everyone kind of know a little bit of background before we jump into kind of our other speakers today, a little bit about HIIQ. So the Healthcare Institute for Innovations in Quality, we have this vision of having Kansas City delivering the highest value, most equitable healthcare in the nation. And our mission is really to catalyze and facilitate multi-stakeholder collaborations to improve the quality of value of healthcare in Kansas City. And I want to thank all of our, sponsors, partners, and supporters, down here at the bottom, BioNexus KC, especially with this forum today, and many other ways they support and help us, as well as UMKC, Mizzou NextGen, as well as KU Frontiers, Clinical and Translational Science Institute. And so, this is obviously very timely today, but in terms of how the QVIC and HIIQ came to be, we really understand that, we're under shifting payment models in terms of the healthcare landscape. Health systems are really struggling to figure out how to navigate from fee-for-service traditional care into value-driven healthcare, where we can deliver care with higher quality at less cost, and this is a struggle. And so what we've really created here in Kansas City is a regional strategy to try and bring together multiple stakeholders, including the providers, researchers, purchasers, payers, community, and patients, to really kind of all come together and figure out how we can, survive and thrive under the changing healthcare payment delivery landscapes. And so another kind of way to think about this is we're really, the IOM and national academies and others have really put forth, the learning healthcare system approach of really how, health systems or units are learning and doing quality improvement and improving, over time, learning and then updating again. And we're trying to think about how we can adapt learning healthcare system models into really a learning healthcare network, where we can have a number of hospitals, in a community who are all sharing and learning together and creating a learning healthcare community. And, the strategies or ways that HIIQ really goes about this. We have three main strategies that we do. So we have first our regional quality improvement projects, which here on the left is kind of a map of Kansas City, and our projects 1 and 2, which are the opioid management project, and then transitions of care for heart failure. And these are really where we are bringing researchers and multiple stakeholders together to actually help each of the individual hospitals use implementation science, implement these evidences into practice, and then use outcomes and evaluation methods so that we can measure the impact of those. And in order to do that, we've also kind of realized that we needed to train a lot of the researchers and hospital staff as well on how to best do that, right? And so we've developed our second arm, which is our training arm, and created TIARA, which is training and implementation actionable research approaches, so that we can actually learn about the science of integrating evidence into care and use those methods in a pragmatic way to change care. And then third, and why we're all here today, we have the KCQVIC forum, and this is really in our dissemination and engagement arm, and where we can really talk about different pressing healthcare topics and priorities in our region and also in the nation, and hear from different perspectives and kind of learn from one another and take those learnings into our own professions and activities. So a little bit of background for today's session, checking my time. So, alternative payment models, this is a topic that's just really exciting right now, and me especially, it's my passion. But so APMs, or alternative payment models, are, part of the CMS quality payment programs, as are, MIPS, the merit-based incentive programs. And so, and we'll hear more about those from CMS. But what APMs are is they're payment approaches that give added incentive payments to provide high quality and cost-effective care, essentially to give value. And APMs have been developed, for specific clinical conditions, for different care episodes or populations. And for a little more background, in October 2021, CMS, or the Center for Medicare and Medicaid Services, and particularly CMMI, which is the Centers for Medicare and Medicaid Innovation, had said that they had the goal of having the Medicare and Medicaid beneficiaries, bennies, covered by alternative payment models by 2030. And CMS has really implemented a lot of different types of these models and demonstrations in both population-based and episode-based care. And then this next slide just kind of shows a little bit of some of the examples of those, and we're going to hear more about these in just a moment. But in terms of the population-based APMs, a lot of these are the ACO models, as well as CPC Plus, which I know a lot of Kansas City hospitals have participated in, which is the comprehensive primary care, the last one. And then there's also these episode-based payment models as well, the acute care episode demonstration, the bundled payments for care improvement, or BPCI, comprehensive care for joint replacement. And so, that's a little bit of background about, I guess, APMs at a high level. But today we're going to hear from a lot of experts who work in this field. It's going to be a wonderful session. And so here's our agenda. So today I've kind of kicked us off with our introduction, and then we'll move to hearing a federal research perspective from Dr. Matt Trombley, and then we'll hear a policy perspective from Dr. Adele Scharzer, and we'll hear from a payer perspective from CMS, particularly from Dr. David Nelsina. And then with Dr. Jerry Blackwell, we'll be hearing a physician practice perspective. And then my colleague, Dr. John Spertus, will be kind of leading our Q&A and discussion portion. And just the last slide I have here is just kind of a snapshot of our year for these forums. If anyone is interested in not yet on our list, our mailing list, to get more information about these, do reach out to Pat McDonald. Her email address is there on the bottom, but you can see our lineup for the year. Today we're on alternative payment models, and then next month we will be giving an update on our Project One, as I had mentioned, for the QVIC. We'll be giving an update on the regional approach to opioid management and the ED. So that's our agenda for the year, and from here, will be happy to turn it over to our first speaker. And and just for everyone here in the audience as well, please do put questions in the chat. Anything you have for any of the speakers, you drop them in the chat. We'll save most of the questions for the end, but if you have anything at all you want to comment on or ask questions about, do drop them in the chat. But with that, I will introduce our first speaker. So Dr. Matt Trombley is a senior health economist at Abt Associates, and he'll be giving us a federal research perspective on evaluating alternative payment models and using lessons from the ACO investment model. So the floor is yours, Matt.
Thanks, Stacey. Are you able to see my slides? Yep. Okay.
Great.
I think I'm getting an echo from somewhere. Okay, perfect. Thank you. So thank you for that introduction. As mentioned, my talk today is going to focus on Abt's evaluation of the ACO investment model. So we were contracted by the CMS Innovation Center to serve as the independent evaluator for this particular model. And I had the privilege of serving as Abt's lead analyst for that. But before I dive in, I do want to just acknowledge that I'm speaking on behalf of what was a very large research team, and I am, gratefully acknowledge all of the contributions that made this work possible. There were just a ton of people that contributed to this, and I also just want to note up front that this presentation does not reflect the views or positions of the Department of Health and Human Services, CMS, or of my employer, Abt Associates. So we'll jump in with a little bit of background on the model itself, and then we'll give a high-level overview of some of the evaluation challenges that we encountered and some of the lessons that we drew from that. This slide is probably review for many of you, but in case some of you are less familiar with the Medicare terminology, I'll just quickly review some of the key concepts underlying the ACO investment model. It was released under the umbrella of the Medicare Shared Savings Program, which is Medicare's flagship population health program. So under SSP, groups of providers called Accountable Care Organizations, or ACOs, combine to take responsibility for Medicare fee-for-service spending for beneficiaries who are attributed to those organizations. And they're attributed if they receive the plurality of their primary care from that ACO's providers. And if an ACO succeeds in reducing average cost per beneficiary below some projected amount, then they can share in the savings generated for the Medicare program, and thus the name Shared Savings Program. However, within this context, it's been noted that participation in value-based payment models has occurred more slowly in rural areas than in urban and suburban areas. As Stacey mentioned earlier, CMS has the goal of trying to get all Medicare beneficiaries covered under alternative payment models by 2030. And of course, part of reaching everyone is reaching the rural areas. On top of that, CMS has also identified the rural beneficiaries as historically underserved under their 10-year framework for health equity, which has placed additional emphasis on rural populations. But participation in these types of value-based payment models, whether the episode-based or population-based, mean taking responsibility for care the patient receives beyond the doors of your practice or your organization, which typically requires certain capabilities. These may be staffing capabilities such as care coordinators or clinicians who can be on call during off hours. It could entail new software or hardware infrastructure investments. And so groups of providers in more densely populated areas that tend to treat higher volumes of patients are more likely to already have these capabilities in place due to economies of scale, or have better access to finances and capital to be able to invest in those capabilities than some of the smaller, lower volume providers in rural areas. So to address some of these concerns, CMS introduced AIM, which was a 3-year model spanning 2016 to 2018. As mentioned, this was a type of SSP ACO program, but it was designed specifically to address financial barriers to participation by providing an upfront influx of cash to the AIM ACOs, as well as 2 years of continuing support based on the number of attributed beneficiaries. So the payments could be recouped by Medicare by the initial shared savings earned by the AIM ACOs. But if the ACOs did not achieve shared savings, then they were not on the hook to repay the initial loans. The AIM participation requirements were designed to ensure the money reached areas that were otherwise unlikely to form ACOs on their own. So ACO providers had to be located in rural zip codes or be particularly small, and AIM participants were also not allowed to be part of a health system, and hospital participation was limited to either critical access hospitals or very small prospective payment hospitals. Now, evaluating this model came with several challenges, and I think one of the biggest evaluation challenges inherent in many of these payment models that I'm sure many folks on the phone have encountered if you've been investigating other models or even models that your organizations have put out there, is that oftentimes participation is voluntary and non-random, and that was the case for AIM as well. So this means we assume that participants are fundamentally different than any potential comparison group, since by definition, the comparison group did not volunteer. And this precludes the gold standard experimental design, which means we must apply a quasi-experimental design, or QED. The most frequent method that we apply in this scenario, and the one that we use for AIM, is known as the difference in differences design, or DID. And so I'll spend just a couple of minutes reviewing this technique and kind of how we applied it. So this shows a graphical depiction of the DID approach, which requires identifying outcomes for non-participants, i.e. the comparison group, as well as identifying outcomes for both the AIM and comparison groups prior to the intervention. We call that the baseline. And the main assumption of the DID is that, conditional on any adjustments we make, such as regression or weighting, any differences between the two groups besides participation in AIM are constant over time. This is sometimes known as the parallel trends assumption, based on the graphical depiction you see here. The purpose of the comparison group in this case is to capture what would have happened to the AIM group during the intervention period if AIM had not occurred. So in this hypothetical example, the dotted blue line tracks the predicted outcome among AIM participants in the absence of AIM based on the pattern observed in the comparison group. So in this case, a small downward shift in spending growth. So even though the outcome remained higher in the AIM group in this example than in the comparison group, the difference still shrank relative to what it was in the pre-intervention period. And the difference between the difference predicted by the dotted blue line and the actual realized difference, that is the solid blue line, can then be attributed to AIM. And so this allows us to account for those selection effects introduced by the voluntary nature of the model, because the differences between the participants and non-participants are differenced out, and that leaves just the impact of the intervention. The evaluation included two primary other challenges that are common in our line of work. So the first is that participants were allowed to change from year to year. So as mentioned, this was a 3-year model, but the underlying providers that comprised each of the ACOs were shifting over time, even as the actual ACOs themselves remained in the program. And this is a problem in the DID context, since the baseline period must have an identical definition of the performance period in order to be valid. And this means we have to rebuild the entire analytic sample every year, including revising the comparison group and revising baseline outcomes. That can make it challenging to apply certain methods when we're under a time constraint. The second challenge is that in these years-long interventions, the policy landscape often changes significantly over time. So for example, the market served by the AIM ACOs saw increased penetration by non-AIM ACOs or other innovation models over time. And this meant that the comparison group was subject to influences in the performance period that were not present in the baseline period. And again, this can bias our DID estimates. So the solution to the first challenge is really just try to adopt as simple an approach as possible to comparison group design. So I think a lot of us are trained in our schooling to try to get the intervention comparison groups as close together as we can in terms of similar characteristics, similar outcomes, usually through some very complex hands-on iterative matching technique or something similar to that. There may not always be time for that, or you may not be able to replicate it exactly on a year-to-year basis as you're evaluating these over time. And so the goal here was to choose something that was sort of sufficient to the job, but maybe not perfect. But what's nice about the DID context is that the intervention and comparison groups don't need to be identical, so long as the differences between the two groups are plausibly constant over time. So this means you're going to reach a point when applying a DID where good enough for unbiased estimates may be less rigorous than the minimum achievable difference between the two groups. So on AIM, what we did was essentially just say any beneficiary who lived in an AIM ACO market who was eligible for ACO attribution but wasn't attributed to an ACO was in the comparison group. And then we just relied on regression and some weighting to account for any remaining differences. So a very simple approach. We didn't use any type of matching besides the geographic constraint living within the same market. The second challenge entailed one of two solutions. So to the extent possible, we did try to replicate the policy environment in the baseline that existed during the intervention period. So just as an example of that, if a new ACO moved into an AIM ACO's market and started soaking up comparison patients during the performance period, we would apply the attribution algorithm to that ACO in the baseline and assign those patients as if they belonged to that ACO in the baseline, and then excluded them in both time periods. And that allowed for sort of a clean break across time periods, provided there were no patient selection effects. Now, in some cases, we weren't able to precisely replicate the policy environment in the baseline. And so in those cases, we would bound our estimates by estimating our models twice. So in one where we would leave beneficiaries treated by other models in the analytic sample, and one where we would exclude them from the analytic sample. And in both cases, we assumed there was some degree of bias in our estimates, but to the extent the two estimates give similar results, that gives us more confidence in our overall conclusions. Basically, if our two wrong answers yield very similar estimates, then we have a better idea of where we're landing. So the first finding from our evaluation is that AIM did succeed in encouraging the formation of new ACOs in previously underserved areas. 41 new ACOs joined in 2016, which comprised roughly 10% of all SSP ACOs that existed that year. And as shown in the figure on the right, relative to non-AIM SSP ACOs that began in the same year, the AIM ACOs were more rural, more likely to include beneficiaries in healthcare professional shortage areas, beneficiaries in higher deprivation neighborhoods, and in markets that were less likely to have penetration from other ACOs. And this slide shows the meat of our evaluation findings, including the impact of the model on total Medicare spending, as well as several measures of healthcare utilization for each of the 3 years of the model. We estimated a separate impact for each year due to the fact that ACO provider composition could change from year to year, as mentioned before. But all of our estimated impacts are statistically significant, except for one denoted by an asterisk over here. But you see the model reduced spending in all 3 years by roughly 3 to 4%, primarily achieved by reducing hospital admissions and readmissions, as well as emergency department use and skilled nursing facility use. These reductions were achieved quickly, so they manifested in the first year and were sustained at similar levels across all 3 performance years. And critically, these changes did not result in increased mortality, nor did they result in reductions in patient-reported measures of care experience or access to care. Overall, the net savings represented more than 2.5 times the cost of the model. So this was a very cost-effective model. With our last couple of minutes here, we'll just discuss a couple of lessons learned. So first of all, it did show there's a willingness on the part of rural providers to participate in these types of arrangements. We can't know for sure that none of these ACOs would have formed in the absence of AIM, but we did see a large and simultaneous influx of ACOs in these predominantly rural areas that typically had no other ACO presence. So that is a very suggestive finding. And we found that they can be successful in these areas. They reduced spending and kept people out of the hospital. But our results also did suggest that continued expansion of these types of models into rural areas will potentially require some level of upfront financial support. But the good news is that CMS has taken these lessons to heart and has introduced several new efforts to encourage continued expansion of value-based payment models. So the first is the CHART model, which provides funding directly to designated steward organizations within each of 4 states to directly invest in rural areas based on the areas of greatest need as identified by the designated communities in collaboration with the steward organizations. And unlike the AIM funding, these funds do not need to be repaid. This is purely just grant money to help improve capacity and develop care quality. The second recent effort is a proposed change to SSP that would allow new ACOs to receive AIM-like investment funds in an upfront and ongoing basis. And the primary difference from AIM is that the proposed rule does not place the same rural restrictions on participation, but rather incentivizes the formation of ACOs that treat a large proportion of low-income beneficiaries regardless of where they live. Now, the neat thing about this proposed change to SSP is that the changes are explicitly authorized based on the findings of our AIM evaluation, which helps to illustrate the benefit of the services provided by organizations like APT, as well as our esteemed competitors, which are used to help guide policymaking decisions. So thank you all for your time, and I look forward to our Q&A session in a few minutes. Thank you, everyone.
Wow, thank you so much, Matt. That was really insightful and that was wonderful. So thank you so much. And just a reminder, anyone to drop any comments or questions in the chat. We would love to address those during the Q&A. And so I'd love to take this time to introduce our next speaker, who is also a dear friend of mine from taking biostats together at Hopkins to baby showers and everything. So anyway, so I'm now introducing Dr. Adele Scharzer. She's a senior research associate at the Urban Institute, and she'll be giving us a policy perspective. So the floor is all yours, Adele.
Thanks so much, Stacy. Give me a second to pull up my slides. All right, there we go. So as Stacy mentioned, my name is Adele Scharzer. I'm a senior research associate at the Urban Institute. And in that role, I deal with APMs in a few different ways. First, I'm part of a contractor team that's spearheaded by NORC that is evaluating and supporting the PTAC, or the Patient Physician-Focused Payment Model Technical Advisory Committee. I'm also working pretty closely with Bob Berenson on thinking about how APMs focused on primary care can help address a number of different issues in our current healthcare system. And then I've been doing some work on telehealth and how that integrates with APMs. So today I'm going to keep it pretty high level from a policy point of view. I'm going to just recap some of the context that spurred the development of APMs about 10 years ago, many of which factors are still very relevant today. I'll give a quick overview of some of the big APMs over the past decade, and then at a high level talk about kind of where APMs are headed. And this is the same definition that Stacy presented, but I just wanted to make sure that we're all on the same footing. You know, an alternative payment model is a payment approach that gives added incentive payments to provide high quality and cost efficient care. That's the QPP definition. And then I need to say that this is my presentation and my thoughts. It does not represent NORC or Urban Institute or the Department of Health and Human Services. So winding the clock back about 10 years before the Affordable Care Act, this was some of the context that we were facing in the healthcare system. We had high spending levels per capita and high growth per capita. The annual inflation rates for healthcare had outpaced general inflation, and that remained largely true. We're in this kind of interesting environment right now where medical inflation is actually a little bit lower than general inflation, given how high it is for everything else. But that's a trend that we don't know what will happen. We don't know if that will put pressure on healthcare as resources need to be diverted to other places, or if healthcare will kind of catch up and we'll see higher inflation in healthcare. These cost pressures have placed a lot of pressure on the Medicare Trust Fund. In particular, we have, you know, per capita growth that's high, but then we also have the aging of the population and increases in utilization that portend the looming insolvency of the Medicare Trust Fund in less than a decade. Part of this high spending is driven by fee-for-service payments that incentivize a high volume of services. Stacy also mentioned this. To maximize revenue, that's not always aligned with what a patient needs or their preferences. We have seen over the years some reforms to different parts of Medicare payment, like the inpatient prospective payment system and the outpatient prospective payment system, but physicians are still generally paid fee-for-service. Further, the Medicare Physician Fee Schedule, or the MPFS, has distortions in it that further lead to the delivery of certain services over others. And that impacts where patients are treated, for example, in the outpatient department versus in a physician office, what services they receive, and then how much they get. Kind of beyond those concerns about cost, we have concerns about access to care, including disparities in access across a number of different dimensions like income and race and ethnicity, and then concerns about quality of care in terms of duplicative services, unnecessary services, and poor coordination. So all of that, you know, in kind of 2009 led to the development of the Affordable Care Act, or the ACA. And then the ACA established the MSSP, and it also established the Center for Medicare and Medicaid Innovation, or CMMI. The MSSP, as our previous speaker mentioned, established ACOs, and we have a number of different ACOs now. And then CMMI was charged with developing and testing new payment and delivery models to improve care and lower costs. They're designed to reward providers for delivering high quality and cost efficient care. And as Stacy mentioned, they can apply to a health condition like end-stage renal disease, a care episode like a joint replacement, a provider type such as a primary care clinician, or a community. One important element of the CMMI authority is that they can waive requirements in Medicare and, to a more limited extent, Medicaid. So that allows CMMI to test promising payment and service delivery changes in ways that are not possible in the fee schedule. A few years later, MACRA rolls along. The Medicare Access and CHIP Reauthorization Act of 2015 created the QPP. This importantly repealed the sustainable growth rate, or the SGR. That was how physician payments had been updated in Medicare for a long time. It was sort of well-intentioned, but it ended up having the effect that each year the SGR projected a massive cut to physician services, and Congress had to act in a very ad hoc way, and it added a lot of unpredictability. So MACRA repealed the SGR. It also changed the way that Medicare rewards clinicians for value over volume. It gave incentives to participate in some of these APMs. It streamlined multiple quality programs under MIPS. And then it established PTAC, as I mentioned. Now, PTAC is a committee of experts appointed by GAO to review stakeholders submitted proposals for alternative payment models, and then give comments and recommendations to the Secretary of HHS on those payment models, which then CMMI could theoretically take and implement. So I wanted to share this framework from HCP-LAN. HCP-LAN is the Healthcare Payment Learning and Action Network. They are kind of loosely affiliated with CMMI, but includes external experts as well. That is a framework for different types of APMs, not so much focused on condition or provider, but in the structure of the APM. The goal is to push as many healthcare dollars as possible into categories 3 and 4, which are kind of higher risk bearing, more population-based APMs. Category 3 is APMs built on the fee-for-service architecture that includes shared savings and those with upside and downside risk for APM entities. And then category 4 includes population-based payments. One important aspect to note is that with APMs, there is an APM entity, right? They're the group of providers, the ACO or group of practices that bears risk and accepts sort of any payments that are part of the model and then distributes them to participating providers. Now, the individual participating providers within these different models may still be paid fee-for-service and may or may not have any significant risk in sort of reducing cost or improving quality. So that's just one thing to think about as APMs are moving forward, is what incentives do the individual clinicians face. So kind of where we are over the past 10 years, some areas of discussion in the design of alternative payment models. What conditions are we targeting? What are kind of the high value areas where costs are way out of line with what we think? Which beneficiaries and which providers? So primary care, and how do we define that? Or cardiologists or surgeons, all of that is when the brass tacks comes due, we have to figure out exactly how we're defining those and how, like, what data we have to define them. In addition, mandatory versus voluntary provider participation. Voluntary provider participation is much easier sort of to digest politically, but many think that the mandatory participation is where we could really start to see more results in terms of improving quality and driving outcomes. We get those, we get everyone, not just the people who are choosing to be a part of a model, but everyone, and particularly those who are not participating, maybe those providers who are most in need of improving their quality. There's been discussion about different patient attribution methodologies. How do we use claims in a prospective way, in a retrospective way, to assign patients to practices, right? Because the APM entity is accountable for the care for their population, but then you have to somehow decide what that population is, and to what extent do patients voluntarily identify their ACO or their providers, and how do we make that work with the other data that we have. A big area of discussion is the structure of payments to participating providers. So are we still mainly paying them fee for service? Are we giving them any upfront investments to help transform their practice? And are we giving them per beneficiary per month payments, such as a care management fee, fees to support telehealth? And if we're doing that, then what services are capitated and then what's still paid fee for service? In addition, how do we keep track of service delivery if we don't necessarily have the claims to track how providers are performing? Another area has been one-sided versus two-sided risk. So do providers just share in any savings relative to the benchmarks? Are they liable for any costs in excess of the benchmarks? There's been a lot of discussion about what performance measures we're using. Are they relevant? What kind of burdens do those performance measures place on providers? It's easiest to draw from information that's already collected, but is that necessarily the right information? And is that what we want to be driving toward? And then the performance assessment methodology, what are our comparison groups? Is it your own historical performance that you're measured against? Is it different provider groups who are in your kind of peer area? Is it, some sort of blended methodology to try to both reward progress and reward an absolute level of achievement in terms of cost and quality? That's kind of where we are. Now I wanted to shift forward a little bit and talk about some of the big picture ideas about where APMs should be headed. In October 2021, CMMI released a strategy refresh, which was mainly a white paper, and I included a link to it at the bottom, but a white paper that talked about their goals for APMs going forward. It's a great kind of quick read and assembles a lot of evidence. But in some, there's mixed evidence on the impact of APMs. 6 of 50 models had significant cost reductions. There's a need to re-examine the APM portfolio to accelerate a move to value-based purchasing and drive broader system transformation. So the white paper summarizes some great lessons learned from the 10 years of demonstrations. And then the paper shifts to talk about some of their objectives. They want to drive accountable care. And part of that is, as Stacey mentioned, to align 100% of traditional or fee-for-service Medicare beneficiaries to a provider in a value-based care relationship. Some other big objectives were to advance health equity, to support care innovations, to improve access by addressing affordability, and to partner to achieve system transformation. So working with other payers and other stakeholders, even better coordination between Medicare and Medicaid, and a more cohesive approach to value-based purchasing. All of this led toward the redesign of the global and professional direct contracting model, which was already kind of a newish APM that CMMI had announced. And they shifted that and rebranded it as the ACO REACH model, or Realizing Equity, Access, and Community Health. And so that's sort of just getting going now. So in addition to the CMMI white paper, MedPAC has been active in talking about what APM should look like going forward. Building on June 2021 recommendations from MedPAC that really focused on streamlining the number of APMs, MedPAC in June 2022 recommended simplifying the number of tracks available to clinicians, such as tracks for different sized organizations, or having one track with various risk levels based on ACO characteristics instead of like an alphabet of different tracks. In addition, they recommended basing benchmarks on exogenous growth projections rather than actual spending. Choosing a factor that will increase kind of fast enough to give providers a chance to realize shared savings while also realizing net savings for Medicare. It's just kind of hitting that right balance of, yeah, hi, Elizabeth. Realizing that right balance of kind of reducing costs, but also not overly penalizing participating providers. And they'd also, MedPAC recommended encouraging CMS ways to strengthen incentives for participation. MedPAC also recommended implementing a national episode-based payment model. They recommended that participation could be mandatory for certain providers or certain proven clinical episodes where the evidence is really strong. In addition, MedPAC carried forward that theme of using alternative payment models to promote equity and reduce disparities. They noted that this would represent a shift from temporarily testing a large number of model tracks at CMMI on a small scale to permanently operating a smaller number of model tracks on a large scale, really just continuing to spread that reach. So to wrap up, 10 years after we've had APMs, the evidence on their impact on cost and quality is mixed but promising. I think the general consensus is that APMs just need to be bigger and more meaningful in their reach to providers and patients. There's a policy focus of simplification and streamlining, kind of making it easier to participate and less confusing for providers. There's another goal of expanding the reach of APMs to more providers, especially specialists who have been less likely to participate in APMs, and beneficiaries. There's also a goal of getting more providers to accept downside risk. And then post-COVID, I think it's worth noting that APMs may be particularly important in supporting and coordinating telehealth and mental and behavioral health and substance abuse treatment, and with their flexibility over payment, addressing health-related social needs like medically tailored meals or transportation or other things that really help the clinical interventions reach success. And then I would say on a really big picture, we need to consider APM payment approaches in the context of our other Medicare payment vehicles, such as physician fee schedule reforms and our Medicare Advantage payments, trying to really make sure that we get the incentives and the valuation of payments right. So that's it. Thanks so much for your time. Sorry about the disruption.
That was amazing, Adele, as always. That was such great history and good storytelling. And I was just impressed also with your focus when, with your visitor. But that was amazing. Thank you. And next we'll turn it to, we have Dr. David Nelicina, who's the CMO for CMS Dallas, the Center for Clinical Standards and Quality. And we'll hear from kind of the CMS payer perspective on the role of APMs in the Q quality payment program. So the floor is yours.
Yeah, thanks, Stacy. And hello, everyone. So I really love these panels when the speakers that precede me do some of my work for me. And so you already know now a lot about the Medicare Shared Savings Program, about the Innovation Center and its history. So I don't have to dwell on those during my talk. I didn't realize I was supposed to have an in-person time checker, and so hopefully I can end on time despite that. But let me go ahead and advance to the next slide. So I'm going to be talking today about the role of APMs in the quality payment program. And so you've heard a little bit about the quality payment program already. It was authorized in 2015 under MACRA. And the general structure is that there are two main tracks in QPP. There's the Merit-Based Incentive Payment System, or MIPS, which is the larger track. It affects the larger number of Medicare clinicians. But then there's also the Advanced Alternative Payment Model track. And if you are in an advanced payment model, advanced alternative payment model, and you meet certain other criteria, you can actually be exempt from MIPS and eligible to receive a separate payment. So this just kind of breaks it down a little bit further for QPP. So just being in an APM per se doesn't get you out of QPP or out of MIPS. You need to be in an advanced APM, and we'll talk a little bit more about that on the next slide. And then once you are in an advanced APM and participating for a given participation year, you need to achieve what's called qualifying APM participant status, or QP status, or partial QP status. If you achieve QP status, then you, by statute, are exempt from MIPS and are eligible for additional incentive payments apart from MIPS. And if you achieve partial QP status, then you have the option of being excluded from MIPS, although there's no special payment associated with that partial QP status. As I mentioned, just being in an APM doesn't sort of get you off the hook. So there are lots of different APMs that have come out of our Innovation Center. I think there's been a total of 50 different models, in addition to the Shared Savings Program, which is sort of separate from the Innovation Center. And all of these are APMs, but only a subset of those are affected directly or to a large extent in QPP. Now, by statute, all of the APMs get sort of special bonus points in one of the categories in MIPS, the improvement activities category. But only if you are what we call a MIPS APM participant do you sort of get special scoring and special consideration, predominantly in the cost category. So when we talk about MIPS APMs, you have to be in an arrangement where you basically have a signed contract with CMS, and you are part of a list of providers in that APM that have agreed to certain participation requirements that are part of that model. If you are in one of those MIPS APMs and are on those lists, then you have special scoring, as I mentioned, and predominantly up to this year, your cost category has been weighted to 0%, which is a great incentive. And it makes sense because being part of these APM models relies on you focusing not only on quality, but also on trying to contain costs. And so since you have this additional incentive through your APM, it made sense for us not to score you on that in QPP. Now, within the MIPS APMs, there's also a subset called advanced APMs. And these are have special requirements related to the quality measures, to the use of certified electronic health record technology, and most importantly, to accepting a certain degree of downside risk, financial risk, as part of their participation in the model. And so if you're in an advanced APM, as I mentioned previously, and you achieve what's called QP status, then you can become exempt from MIPS and eligible for additional incentives. Now, we talked about QP status, and so the way we look at that is looking at two different criteria. The first is the amount of your payments, and this is normally your Medicare payments that are delivered through the APM in which you're participating. And the second is your patient count, so the number of Medicare patients that you treated through the advanced APM model that you are part of. I will mention at this point that we have extended the QP criteria to include other payers and non-Medicare payers, so that there are separate criteria if you are in a Medicare APM as well as another APM. We include that in the consideration of whether you've met QP status. Now, we've originally the QP status thresholds were going to go up to 75% and I think 40%. But the Consolidated Appropriations Act that was passed at the end of 2020 froze these thresholds at the current level of 50% and 35% for the through this year, 2022. We don't know what will happen after that. We'll have to wait and hear from Congress. But these are the current levels that you would need to exceed in order to meet QP status. So if you do meet QP status, then in addition to being exempt from MIPS, you are eligible for a lump sum payment based on your Medicare Part B professional services. This was a 5% payment that extended through this year, 2022. And so you got this lump sum payment that was based on all of your Medicare Part B, even those outside of the APM that you were participating in. As I mentioned, this year is the last year that you can earn those payments, and the last year those payments will be made will be 2024. And as I mentioned, these are based on your Part B covered professional services, so it's not all of your Part B services. But it does include, if you are a clinician who meets QP status, it does include your Medicare payments for all of your 10 MPI combinations, even those outside of the advanced APM. All right, so for those who don't meet QP status, you are still expected to participate in MIPS and report to MIPS. You can do this as either an individual, a group, a virtual group, or through the MIPS APM entity that was mentioned earlier. If you do use your APM entity for reporting, your cost performance category will be related to 0%. And beginning last year, we created a new way for MIPS APM participants to participate and report called the APM Performance Pathway, or APP, and I'll talk in more detail about that. If you are participating in MIPS and reporting, you will also be able to report using a new method called the MIPS Value Pathways. These will go into effect in 2023 and be an option for reporting in 2023. And these are a set of measures, related measures in the quality, cost, and improvement activities categories that are designed to be more relevant to clinical practice and to streamline the reporting and hopefully make it more meaningful. So this will be available next year, and APM participants have that as an option under MIPS. I mentioned the APM Performance Pathway, or APP. This is a new reporting framework that began last year and will be available again this year and going forward. It's only available to MIPS APM participants. It is required for those participating in the Medicare Shared Savings Program, those ACO participants. And it's available for reporting either by individual clinicians or groups or at the APM entity level if you are a MIPS APM participant. So you have some flexibility and options in terms of reporting. The APP is complementary to the MIPS Value Pathways that I mentioned, and it is composed of a fixed set of measures for each performance category. So we modified this starting last year, and we finalized the measure set for the APP to include the CAHPS for MIPS survey. This is a consumer satisfaction survey. There are 2 administrative claims measures, and there are 3 electronic clinical quality measures, or MIPS CQM quality measures, that are part of the APP measure set. Now, originally we were going to be retiring the web interface method of reporting, but based on stakeholder feedback, we have extended that for the Medicare Shared Savings Program for an additional 3 years. And so as part of the APP, the Medicare Shared Savings Program ACOs can report using the web interface instead of the 3 ECQMs or MIPS CQMs for the next 3 years. This slide just shows the quality measures that are part of the APP. At the top are the 3 ECQMs or MIPS CQMs, and then the entire set on this side includes the CMS web interface measures. So you have the option of either reporting the web interface, all of these measures, or just the top 3. This is only if you are not in the Shared Savings Program. The Shared Savings Program are the only ones who can do the web interface. And then these are the remaining 3 measures, the CAHPS for MIPS survey and the 2 administrative claims measures. All right, so I am very short on time. If you report the APP, you will receive a full score for improvement activities in 2022. You will continue to report your promoting interoperability data at the individual or group level for 2022. So you cannot report it at the APM entity level for this year. And so we will take an average of the reporting across those individuals and groups and apply it to the APM. As I mentioned, the Shared Savings Program has the option for the next 3 years of reporting the web interface as part of the APP, but beginning in 2025, they must report the 3 ECQMs or MIPS CQMs in addition to administering the CAHPS for MIPS survey. And this slide just shows the scoring differences, the weighting differences between traditional MIPS and APM entity reporting and the APP reporting. You'll notice that for APM entity and APP reporting, the cost category is reweighted to 0%. And there are small differences between the quality category weights between traditional MIPS reporting by APM entities and the APP reporting. All right, in just 1 minute, I'll just mention that we do have a number of proposals out in our physician fee schedule proposed rule. We have a number of changes proposed for the Medicare Shared Savings Program, trying to increase participation, especially among small and rural and underserved populations and practices, as well as making improvements to the benchmarking methodology. We've made some changes to the advanced alternative payment model under the quality payment program, making permanent the 8% minimum generally applicable nominal risk standard, and making some changes to the way we determine the 50 clinician limit for the medical home model. We also have some requests for information out related to the payment gap for advanced APMs that will go into effect next year, and also to a potential way of changing the quality QP determination at the individual level. The comment period closes September 6th, so I encourage you to review our proposed rule and provide your comments for our consideration. And with that, I will stop. Thank you.
Thank you so much, David. That was wonderful. Really good context and background, so thank you. And next up, we will be hearing from a physician practice perspective on where do physicians fit in. And this is from Dr. Jerry Blackwell, who is president and CEO of MedAxiom. So Jerry, I will give it to you.
Thank you so much, Stacey. Let's try this, and let's see here. Can you see it okay? Thumbs up here. Good. All right, well, I will jump in here, and I can't tell you how appreciative I am to be asked to be part of this. I just loved hearing what the folks ahead of me had to say, and I will add a slightly different perspective on here. And it's just such a bummer that we're not in person so that we could sort of read the body language and have a chance to interface. It's important that I say up front, I am absolutely committed to these changes that are being made. It's crucial, I think, for our profession that we proceed down these tracks. But I don't want anything that I say to be interpreted as being trite or short or anything. But John asked me to talk about the physician practice perspective, and that's what I'm going to do. And my perspective is going to be that the docs are a little bit in the dark on this. So let me just walk through this very quickly. I'll start with this and say, after those beautiful talks, and I really mean this, I've heard this stuff a lot, they were fantastic. But if you're not confused, you're not paying attention. It's just, this stuff's complicated. It's not a little complicated, it's very complicated. And with that, just quickly back about myself, I'm the president and CEO of MedAxiom. We're an ACC company. And we focus on organizational performance improvement. I'm a practicing cardiologist, continue to practice, but fortunately I have a window to practices throughout the country, and that's what I'm going to share with you here. I'm not speaking on behalf of the ACC. I'm just giving you my perspective as the MedAxiom CEO. But the most important disclosure I have is one my wife makes me put on every talk, and that is I'm wrong all the time. So it's possible. Don't take anything I say here as gospel, but certainly my distillation of where we are. So MedAxiom, just quickly, the ACC is the home for science and education quality for the practicing cardiologists with 54 or 5,000 folks. MedAxiom is all about organizational performance solutions. So I get to interface and touch the country at an organizational perspective, as well as, again, having continuing to practice. I'm giving you those points of view. We'll start with this. In the first is that this is from a MedAxiom survey that shows cardiologist ownership. And if you go back, specifically have 2008, 2018, if you go back to 2008, 90% of cardiologists were in independent practice, 90%. Only 10% were in an employed model. And over the course of 10 years, that completely switched. And if we go out to 2021 now, I just want to show you how it did over 10 years. It's completely inverted. About 90% are in an employed model and 10% are independent. Why did that happen? There were regulatory changes related to reimbursement. There were a variety of legislative things that occurred, budget reconciliation, that caused a complete shift in how folks think. Now, why does that matter to this talk? It's because when folks were in independent practice, they were highly engaged and focused on this topic. Now that the majority of cardiologists and actually the majority of docs these days are in employed models, the docs have checked out on some of it, not completely, but checked out on some of this for reasons which I hopefully can explain. So The healthcare marketplace is known to all of you folks. Let's think of it as it having 4 separate areas. We have the cardiovascular practices, and then we have healthcare systems, industry, payers. And if you put it like that, 3 of those, the payers, the industry, and systems, are highly consolidated. Cardiovascular practices are dwarfed compared to these, and very pedestrian in how they have access to true data and analyze the data. To put this in some perspective, only one health system would be in the top 10%, in the top 10 of healthcare companies by revenue, and that health system is Kaiser, and we all know what a large, sophisticated system that is. So physicians are historically woefully underrepresented in the marketplace of creative disruption, and really have been focused on, am I employed or am I independent? That's very relevant to how we interface with the APM world. And so again, I just say most docs don't understand the details of payment and reimbursement. I'll go over some of the complexities as to why that's the case. And I will offer up that most docs prefer not to be deeply involved in the business of medicine. I say that as a guy, as a doc who is deeply involved in the business of medicine. Most don't want to be. Part of the problem here that you can't get from talks is the regulatory environment, and change happens so fast, it's very unnerving to the practicing docs. These aren't theoretical concerns. These are real concerns that have affected the APM adoption, and our first 3 speakers discussed that at various levels. Technological advances have rapidly outpaced operational advances. That makes it unnerving for the practitioner to understand exactly what the rules of the game are. We talked about rural physicians being at a disadvantage, and things that are spent trying to fix that. I can tell you, I practice in an area served 9,000 square miles, completely rural in Northeast Tennessee, Southwest Virginia, and these things are very, very hard for most of the docs there. And then, of course, there's a tension between primary care and specialists that should never drive what it is that we do. This has to be about the patients and society. But what I'm telling you, the way we're set up right now, there is tension between those 2 subsets. Just again, I love factoids. And here's something. This is coding and reimbursement. And I know that's not what we're talking about, but to give it some perspective, because I'm sorry I don't know exactly who all is in my audience, docs and versus other folks, administrative and industry. But Duke University right now, and this comes from Uwe Reinhardt, a posthumous book, Priced Out. If you haven't read it, you all need to. He's obviously was one of the patron saints of the healthcare economics. Noted 957 beds in the hallowed halls of Duke University, and there's 1,600 coding clerks. Now, I just put that as some perspective as it relates to the complexities of alternative payment models, because that trickles down into healthcare organizations, et cetera. The hospitals and practices employ these coding agents and billing agents, and insurance company tries to control the process very understandably. This is complicated. And I'm not going to dwell on this, but docs, when most docs go into practice, they're thinking about care. This is a beautiful, famous painting that many of you will be familiar with. I won't focus on, but I can tell you, nowhere in the middle of this is sort of the economics of medicine. This is obviously a doc that's been up all night dealing with a young patient that looks sick and maybe terminally ill, mother, distraught in the background, father, difficult, the light coming in. This is sort of what you think of on the practice side. Yet these days, the physicians that come out, this is what they're exposed to, this notion of the industrialization of what we're doing. All has huge technological advances, and ultimately we can make this better for patients and society. But this industrialization, it includes needing to be familiar with governance, management, finance, insurance, health insurance, not just private insurance, but government insurance. As I said, coding, billing. Are you hospital-based? Are you physician-based? Information technology, business law. These are all things that are have to be harmonized into what folks are doing right now. And if you look at all these various terms, you can see why this is confusing on the physician side of things. And that's why it's become rather difficult for the adoption of this inside or understanding the doc's perspective. I'll just sort of close, 'cause I want to leave lots of time for discussion here. So let me offer up what's the main problem for with alternative payment models, or the solution? Is it the quality? Well, maybe. We just talked about that a little bit. Is it an access problem? Maybe. I think that most of us would say non-cynically, honestly, that it's a financial problem, and it's a darn big one, and it needs a solution. But I think that we should be honest that the main thing that we're dealing with here are issues related to healthcare finance that we need to try to solve. I think the question, do we inadvertently create winners and losers based on geography, specialties, high performers? I can tell you in the field, touching the country in this, the answer to this is unequivocally yes. You think of these very sophisticated talks that you're hearing today and this QVIC, which is just a model for the country. But I can tell you this is the choir in the room. The average doc or provider team, part of the care provider team, just can't spend big portions of their day doing this. So it has to be sort of deaconed out to other folks in the organization. And another underlying theme here, and I'm sure you all have already gotten this very quickly, if you want to do this well, you have to have a lot of data. Well, I can promise you there are many organizations, independent organizations, that don't have the data. That gets back to are you independent or are you employed? So we just have to be cautious about all this. And then the final thing is, can you take this information and explain it to really smart, reasonable people? And most of what we just talked about is hard. Even taking MACRA, it's probably the first time that we've come up with an acronym that has an acronym inside of the acronym. These are complicated topics to explain to somebody that you also want to be there 24 hours a day for the needs. It's really hard. Now, I just cherry picked 3 articles here that I'm not going to go through in any detail that I thought added that you could have to take a look at that sort of highlight this. These are cherry picked. Again, I don't mean to be providing really detailed data related to this. This is from the Journal of Hospital Management and Health Policy, talking about physician perspectives about the US QPP. And this is from 2020, and it just makes for an interesting read. And the point that they're making is not to diss the programs. Everybody gets this, but just saying the docs would rather spend their time elsewhere because it requires big amounts of data. It's very hard to explain in a short period of time. And I will say the most important problem with this is, from the doc's perspective, is that the rules of the game sometimes change in the middle of the game. There have been regulatory changes that have adjusted these APMs, and that is very unnerving to the physician community, provider community. Here's an article from the RAND Health Quarterly that is interesting because it has a 2014 perspective, asked the same questions in 2020, and the answers are very similar, saying, look, we'd rather spend our time elsewhere than trying to understand all the details of this. And then finally, this is one actually, it's in the American Journal of Accountable Care. It actually has patients from Canada. So it's a non-US discussion of the similar topic, but it's related to the impact as it relates to specialist physicians. So it's there's plenty of data out there, and it's worth considering this in the context of what we're doing. So I'll wind up by just saying there are business and regulatory complexities that are causing physicians to reconsider their priorities and options. Private equity is a huge influence these days. I know that's not what we're talking about here, but if private equity starts taking over all these practices, there'll be a completely different set of things we need to consider. Provider burnout. I know that's not what we're talking about. And I'm just going to offer up respectfully, as a guy who's completely committed to this process, I can just tell you, executing against current alternative payment models is not at the top of the list of priorities. Now, what are the top of the list is, I'll end up right here. The end is, top performing organizations, rather than the APMs themselves, they want to be focused on patient-centric decisions, team-based care, leadership that's not just about the provider, but about the entire team that includes all of the brilliant administrative folks that help make this tick. Very interested not just in transactional work, even with the U.S. government, we're interested in partnerships in optimizing where the patients receive care, not just all hospital-based as it's been historically. A huge opportunity to reduce medical waste. Docs will engage on that, and I think there's ways to approach that. If you had to say one single thing that's driving healthcare in the U.S., many really smart folks would say it's the price is stupid. Okay, I mean that is a way to think about this. If we can come up with creative ways to reduce our pricing. And again, these final things on the holistic and data-driven solutions, medical professionalism, and advocacy are all relevant. So I will wind up there, hopefully pretty near on time. I hope, again, beginning or ending as I began, I am completely committed to this process. I'm just telling you, it's difficult for the primary care doctors, what I see, the primary cardiovascular specialists and their interface with primary care physicians across the country. I will be happy to answer any questions. I'll put my contact information here. It's very simple. And Stacey, I don't know, I hope folks will get all these slides. That's my cell phone. If I can help or answer any questions, I'll be happy to. So thanks for including me.
Thank you. That was wonderful, Jerry. Thank you so much. So at this point, I'll turn it over to Dr. John Spertus to lead kind of the Q&A and panel discussion.
Yeah, so first of all, I just cannot thank all of you enough for the time you've invested in preparing and sharing your experiences and wisdom. And boy, I've been taking a list, and I've just got, this is just page one of the list of questions I have. So we don't have a tremendous amount of time, but you know, before I get into some of the technical questions, I wonder if all the panelists could think about commenting on some of Jerry's points. So, you know, the fundamental premise here is that we can construct a more rational payment model that could improve the patient-centeredness and outcomes of care while also lowering costs by getting rid of waste. And, you know, one of the challenges I have is if you could get the senior leadership of a health system to participate in an APM program, how will you deal with sort of Jerry's concept that, you know, the physicians are not particularly engaged? How do you get physicians to be aligned? And are there ways within any organization, there are often, you know, certain groups, for example, in our place, cardiology happens to be extremely, you know, innovative, very cohesive. You know, they'd be very interested in a carve out for cardiology, but from the payer's perspective, often they, you know, really want a total cost of care. They can't micro cost out or micro risk certain specialties or divisions particularly easily. So, you know, the question is really, how do we think about designing these kinds of programs so they're simple enough that clinicians can understand them? And how do we motivate clinicians to rally around doing this, especially when they're employed, they're busy, they're overworked, understaffed, et cetera. And I really want to open that up as a broader discussion to the whole group, if possible. Do I really have to call on people?
Yeah, well, I'll try to start. And so, yeah, it's really challenging, you know, the physician engagement and also the level of complexity that's associated with these efforts. And, you know, from a CMS perspective, you know, we have some restrictions on what we're allowed to do. So we can't just sort of throw out the current system and put in a new system, which is why so many of our APMs are sort of built on top of the fee-for-service system with, you know, kind of tweaks on the margins, because that's all the authority that we have. Now, we are trying to extend that in some of our newer models to you know, have an option for total cost of care for those that are willing to take on that much risk. And that would move us, I think, in the direction that we would like to see us get eventually. But getting there is going to be a slow process. The complexity part, I think, from a CMS perspective, is, in my mind, primarily based on our need to understand what's going on and knowing when we actually have found something that works versus something that maybe looks like it works, but it turns out that it was an aberration of the data. And so, you know, we have to a lot of the complexity in the models is trying to make it fair for the participants. And so in order, for anyone who's tried to do risk adjustment, the more fair you want to make things, the more complicated the risk adjustment gets. But then the other thing is our oversight of the models introduces complexity, because we need to make sure that the participants are actually doing what we expect them to do, and that if they get, say, the shared savings or whatever the financial incentives, that they actually did the work to warrant those incentives. And so it's hard to get rid of that oversight and also get rid of the efforts to be as fair as we can to the participant.
David, to be very, sort of concrete on an example, does CMS have the flexibility? So, new evidence. So angioplasty is one of the most common procedures done in cardiology. Evidence has come out that there's really no benefit in stable coronary disease if the patient has no chest pain or angina, but there's a lot of benefit if they do. I embarrassed to say how long ago this was, but I think George Diamond wrote a perspective piece in the New England Journal 25 years ago around sort of paying for value. The more benefit the patient gets, the more the reimbursement is, and the less benefit, the less the reimbursement. That seems to be a concept that, for example, cardiologists could really understand and act upon to sort of ultimately really increase the use of medical therapy in asymptomatic patients and less expensive procedures. Does CMS ever contemplate something that granular, or do you have to be at such a high level that you really can't get into something that would be more actionable by practitioners?
Yeah, I think we think about that a lot. I don't think we have the authority to do it at that level. So for Medicare payments, a lot of it hinges on medical necessity. And so you just have to, and so a lot of that decision-making is left up to the frontline clinicians. And then we rely on, for our coverage, we rely on there being evidence that in certain cases it makes sense. And so then we balance that. And then, of course, we can do audits and stuff to make sure that there's no inappropriate overuse or fraudulent use of services going on. But in terms of customizing the payment based on the particular patient, I think we're kind of at an all or nothing authority. So either it's not medically necessary and so we don't pay for it, or it is and we pay the same amount. So I think
I guess I'm just trying to suggest that, in patients with the same ICD-10 code, sometimes it's really necessary, sometimes it's not. And is there a way, it seems like it's at such a high level, you can't get that granular, and I'm very interested in sort of Jerry's thoughts about how we engage physicians to embrace some of the opportunities to sort of succeed in these at-risk models. But, the more concrete and granular some of the payments incentives were, the more actionable I think it would be by physicians, because then it's got real clinical relevance to their everyday decision-making.
Yeah, John, and David, thank you for your comments. John, I agree with you completely. And I want to make clear, I'm so scared that from a hotel room in North Carolina, I've been completely depressing to everybody and saying docs aren't going to engage it. That's not it at all. There has to be a way. But John, to your point, I think we're going to have to come up with some solutions that are more specific. And I think part of the interesting thing, MedPAC. There's even fighting sort of internally about how we go about some of these things. Do you have a bunch of small programs going at this, or do you do some really big things? I think where the physicians can do very, very well. And John, as you know, John, I should say to everybody else, I can speak, I think, with a measure of authority in the cardiovascular space, which obviously has huge epidemiology associated with it. But I don't want to act like I'm speaking for organized medicine or even cardiology, but I have some authority on the cardiology side. Cardiologists will engage on the cost side of the equation and appropriate use, et cetera. I think there are some ways that the cardiovascular specialists can engage with that. And my suspicion would be specialists in other fields. And I think that the way to attack most of this is what John's getting at, and that is, again, when we talk about the value, for most of us, it really is about the cost. Let's eliminate the very low value things, or those things were just are clearly all good folks know shouldn't be done. I believe there's ways to come up with payment models related to that.
Thank you very much. Adele, let me just ask you a question. Obviously in formulating policy, equity is a very important component. But how is that sort of being assessed and rewarded in the thinking about current sort of evolution of these alternative payment models? And I can speak from experience, we've tried to introduce a very novel program in our health system to address the social determinants of health, leveraging the Mid-America Regional Council and a remarkable program they've built to help patients with social determinants of health needs better and more efficiently access community-based resources than just giving you a list and telling them to go call. But it costs money. And the hospitals have been reluctant to do that because they think it runs afoul of other regulations that preclude incentives for patients to come see you. And so, I'm wondering sort of first how, policy can think about measuring, incentivizing, rewarding better work with equity, and how we would be able to sort of support innovative models to address local needs that contribute to the inequities in the care and outcomes that our patients in our communities have.
That's a great question. I think equity and addressing social determinants of health comes up in a number of different ways. I mean, first, there's sort of the focus of the model. As Matt mentioned, the MSSP proposed rule talks about changing the focus to include more low-income people, right? So that's one way, like by including more people, more vulnerable communities in these models, you broaden the opportunities for kind of the benefits of APMs. There's also a lot of work about kind of accountability. So providers who treat disproportionate numbers of vulnerable patients, like how do we account for that in our performance measures and our risk adjustment? We want to support them. We want to give them the resources they need to treat these patients. We don't want to unfairly penalize them for different performance levels, but we also don't necessarily want to say that it's okay to deliver lower quality care to more vulnerable populations. And then there's sort of the flexibility to address social determinants of health, right? So this, referring to community-based organizations. I think one point that's come through in some of the discussions I've had is that supporting healthcare organizations to do this referral work and screening work is important, but you also have to make sure that the resources are there in the community so that it's not a referral to nowhere, right? I mean, you can only do so much, but if the housing assistance isn't there, then it's sort of a lost cause. So it's a multifactorial approach to dealing with health equity.
Well, I realize it's incredibly complex. I just wonder how you're going to solve it.
I think chip away at it a little bit at a time, right? I mean, that's all that any of us.
But how are they thinking about approaching it? Are we directly measuring equity and inequities? Are we rewarding, closing the gap? Are we, creating sort of tools? I mean, just saying that we're going to make it easier for smaller, groups that participate in APMs assumes that APMs in and of itself improves care. And that's not completely clear to me. And so I'm curious how we're going to make more visible and transparent the incentive to achieve better equity.
Yeah, so there's directly measuring it, right? So having some sort of health equity quality measure, which I don't think we have in our toolbox yet, but I think there's an appreciation that that's something that we should have for providers. There's sort of performance measurement and how you represent the data. Do you stratify it by different risk groups? Do you say, outcomes for different vulnerable populations? I mean, just making the performance measures more transparent. There's also sort of direct resources to support that, right? Instead of saying, hey, we'll increase your bonus a certain amount if you achieve these targets, let's give you some upfront payments to address health equity issues. I think I don't think we have any one clear approach yet, but I think people are noodling over kind of how do we combine these different levers of risk adjustment and financing and risk adjusted payments to try to bring to bear some fruitful solutions.
Well, yeah, we're the, in Missouri, it's the show me state. So we're very excited to see what you guys end up developing, because I think it's very important, will be very helpful. Matt, for fear of letting you off the hook, one thing that just really amazed me about your data was how fast the cost savings accrued. I would have expected that year one, there'd be no or maybe minimal improvement and that it would accrue over time. But it looked like the change happened very, very rapidly and it sustained. And why do you think that is, especially given that there was a need to invest in infrastructure and rethink, sort of strategies of care provision? Why was the change so fast and why did it not improve further over time?
It's a good question. So in terms of the rapid improvement, there is other research by Mike McWilliams and others that shows that's not abnormal within SSP overall. So I think the general shared savings program tends to be able to generate these rapid levels of savings. So I think what it shows is that there's a lot of low-hanging fruit available when organizations are properly incentivized. In terms of saying exactly what that looks like, I mean, it really varied from organization to organization. There were 41 participants, and they each kind of had different approaches to how they tried to address these issues. I think, one of the things that might have helped is many of the organizations in these rural areas did partner with third-party management organizations. So they came with a lot of institutional knowledge that may be lacking in some of these smaller providers, and that helped them get up to speed, kind of matching what's achieved by the more health system hospital-based SSP results that we'd seen previously.
I mean, do you think, I always fear that, I think more about this in the Medicare Advantage space than this, and I don't fully understand the metrics, that really what's happened is that we've gotten much more efficient at coding the acuity of the patient. And so the projected risk adjusted costs go up a lot, but really nothing's changed. Is that contributing to some of this, or are there ways of figuring out that, look, really what made the difference is the ED visits or the, attainment of certain other performance metrics that really led to this? I mean, is it different in every organization, or is there sort of one thing, or could it all just be essentially a byproduct of coding or other administrative changes?
So I will say we're very confident that these findings, and I think this extends to kind of the whole ACO literature as a whole, that it's not attributable to coding artifacts. The way that we run this difference in difference design, and in our case, controlling for only lagged risk score, so basically everything prior to the baseline, before there was any potential changes in coding, many studies often just exclude that particular risk score altogether and just kind of control for other certain factors. So when you apply these kind of approaches, looking at that sort of counterfactual world where you have these providers who aren't in ACOs that you're comparing against, you can get a pretty clear sense of the fact that there are real savings. Now, it is true that potentially some of the shared savings being given out are due to that type of changes in coding, because it's under a different methodology against the benchmark there. But it's undeniable that these ACOs are succeeding in saving money by keeping people out of the hospital. Now, in terms of what we found, I'm not sure there was any one silver bullet in how they did that. There were, more availability of care coordinators to try to, work with people, making medical professionals on call during off hours, so people didn't feel they had to go to the emergency room. I think moving forward, there'll be a lot more use of telehealth. That wasn't as big in the 2016 to 2018 range, but I think certainly it's becoming much bigger now. So I think that will play a key role moving forward as well.
Well, great. Well, listen, I just can't thank all of you enough for your time and sharing your wisdom and experience. And being midsummer, we had a little bit less of a turnout than we normally do, but we get a lot of hits on these after the fact. And so it was very gracious of you to let us record this. I know that I'll be reviewing this with a lot of our fellows, because there's just a lot of wisdom here that really will be very helpful. And as Jerry said, a lot of our trainees just don't get exposed to this, but they need to. And so you all have tremendous wisdom, perspective, experience. So thank you so very much for sharing it with us.